Welcome back to nutrition. This is part 2 of our lectures on nutrition, and we're going to start looking at the nursing assessment regarding nutrition. So nutritional assessment ensures that the patient is having adequate nutrition. Are they malnourished? Malnutrition can mean too little or too much. Obesity is a form of malnutrition. We want to take into account a person's protein status and vitamins and minerals. The Mini Nutritional Assessment, or MNA, was developed by Nestle Nutritional Institute, and it is a quick way to gather data on your patient and evaluate how nutritionally healthy or unhealthy they may be. A nutritional assessment starts with taking a good diet history. This is a 24-hour recall of intake. If a patient is unable to recall everything, you can use family or caregiver information. Keeping a food journal is helpful. There are lots of apps out there to help you track food intake, exercise, recommendations for calorie, protein, calcium intake. And it just depends on the person. They may prefer doing a paper written diary versus an app. It's just their comfort level with technology. I also want to focus on nutrient composition. Consider food allergies, economics of the person, the patient that you're evaluating, their culture, and their ethnicity. To better assess nutrition, we need anthropometric measurements. This can include the height and weight to get a patient's ideal body weight. We use what's called the rule of 5s for women and the rule of 6s for men. This would be a 100-pound female for 5 feet. You add 5 pounds for each inch. For men, if you have 100 pounds of body weight, you add 6 pounds for each inch. The body mass index is the weight in kilograms divided by the height in meters squared. Also look at skin fold measurements. We use calipers, such as shown in the picture up in the right upper corner. We do skin fold measurements to measure triceps, abdomen. Skin fold measurement, and especially on the triceps, is an easy measurement that's used oftentimes in health promotion programs. You want to look at the mid-upper arm circumference, as well as waist to hip ratios in inches. 0.5, 0.8 or greater in women, and 0.95 in men shows an increased risk for coronary artery disease. Waist circumference in inches greater than 35 in women and greater than 40 in men increases risk for coronary artery disease. This is where we start to see that, that more apple shape and the carrying weight in the abdomen becomes dangerous and can lead to multiple disease processes. When we're measuring the measurement of the size and makeup of a body, 500 milliliters of water equals 1 pound. Notice that rapid weight loss or gain can signify fluid shifts within a patient's body. This may be a familiar chart. This is the body mass index, or BMI chart for adults. Weight is on the vertical column, measured in pounds, and height is on the horizontal column. Other calculations to be familiar with is resting energy expenditure, or REE, and total energy expenditure, TEE. There's an equation called the Harris-Benedict equation. This is used to calculate the kilocalorie needs for hospitalized versus non-hospitalized patients. There are multiple steps to help calculate this. Step 1 is to get the REE, the resting energy expenditure. For males and females, this is done differently, and you look at the equations here. We want to get the weight in kilograms, the height in centimeters, and then their age is the data that we need. And you just plug in those numbers based on your patient or the individual that you're doing your assessment on to get your REE. The next step is to figure out the total energy expenditure, and this will be the resting energy expenditure times activity factors. Activity factors is how active is that person or patient you're doing your assessment on. Light or no activity is 1.2, light activity 1.375, moderate activity 1.55, up to very active is 1.9. The third step is to multiply all of this together. Your REE times the activity factor times a stress factor. A stress factor is used only for the hospitalized and acutely ill patients. This takes into account certain stressors on the body systems, such as if the patient just had surgery, are they in anabolic metabolism where they're burning through muscle mass, running a fever, fighting cancer tumors, soft tissue trauma and bone fractures, peritonitis, or fighting off a major septic infection. Then there are other kilocalorie calculations, where we look at age in years, weight in kilograms, and height in centimeters. For men, the REE would be plugged into this equation using 9.99 times weight, 6.25 times height, minus 4.92 times the age, plus 5. Then women, you see the calculation there as well. 9.99 times weight, 6.25 times height, minus 4.92 times the age, minus 161. Once you have your REE calculated, then you can multiply by activity and stress factors. There are other nutrient requirement calculations. It's important to know these calculations. They help show whether or not your patient is getting a nutritionally dense diet that's appropriate to help them, especially if they're trying to heal a wound or fight off a disease process. We'll take a look at calculating grams of protein a day, grams of carbohydrates a day, and grams of fat a day. This is what the patient or individual you're doing the assessment on needs per day to maintain their body functions. Here's some examples of some calculations. We're going to first look at BMI, or kilocalories a day. We have a 45-year-old female who's 135 pounds. This would be equal to 61.3 kilograms. They are 5'5", which is 165.1 centimeters, equals 65 inches. There are some great apps out there that help you quickly do these conversions. BMI is the weight in kilograms divided by the height in meters squared. So you take the 65 inches times 0.25 to get 1.63 meters. Then 61.3 divided by 1.63 squared is equal to 23. So a BMI of 23, you look at your chart and see is that a range that is within normal, less than normal, or overweight, trending towards obese. Another form of doing REE is using this Mifflin-St. Jeor calculation. This is the one using the age, weight, and height to get your REE. And you'll see that we get pretty similar values, 1,398 calories. Now let's look at examples of calculating grams of protein, carbs, and fat per day. We have a 50-year-old female who's 5'6". Let's make her 167.6 centimeters. She's 140 pounds, which makes them 63.6 kilograms. Ideal body weight is 130 pounds, which is equal to 59.1 kilograms. So let's figure out the ideal grams of protein a day for this person. Take the ideal body weight in kilograms times 0.8. This gives us 47.3 grams of protein needed for this female a day. Now let's look at the grams of carbohydrates needed. We take the kilocalories a day times 0.55 divided by 4. This gives us 289 grams of carbs a day needed. Now grams of fat. Kilocalories a day times 0.3 divided by 9. For this female, that gives us 70.2 grams. I encourage you to practice these equations, look for references in your book at ATI, because you'll be doing them on your nutritional assessment and reviewing them as well. There's important lab data to review to evaluate protein, and it takes more than one lab test to evaluate a person's nutritional status. Prealbumin is an accurate view of recurrent protein metabolism. Normally taken over 2 to 3 days is the half-life of prealbumin. A normal range would be 18 to 36. As we start getting lower, we get into mild depletion, moderate depletion, and severe depletion. Albumin is the main protein in blood. Its levels decrease in malnutrition, burns, hemorrhage, kidney disease, and other chronic diseases. The normal range for this is 3.1 to 4.3, and you may see in ATI 3.5 to 5. Sometimes lab values can be a little different, but depending upon the healthcare system in which you work. Transferrin has an 8-day half-life. It responds quickly to changes in protein intake, increases in iron deficiency. There's a decrease in protein deficiency. So a normal transferrin range would be 240 to 360 milligrams a deciliter. Also want to look at labs that indicate oxygen carrying ability. The hemoglobin. When there's a decrease in iron in the system and decrease in iron deficiency in other anemias, you'll see hemoglobin drop. It can also drop after surgery, traumas, and other illnesses. A patient will need a blood transfusion in a hospital setting, usually when hemoglobin drops less than 7, or if the patient becomes symptomatic. Symptomatic low hemoglobin might mean a low O2 saturation, low blood pressure, the patient becomes lightheaded and weak and feels short of breath. The hematocrit is the percentage of red blood cells in the blood. It can be a function of nutrition, especially protein intake. The serum iron is the amount of iron bound to transferrin. It decreases in iron deficiency. And then the total iron binding capacity is the measurement of proteins available to bind with iron. Other lab indicators to signify nutrition include total lymphocyte count. This decreases with protein depletion. The BUN, or the blood urea nitrogen. This is the measurement of nitrogen balance. Urea is the breakdown of amino acids. A normal BUN is between 8 to 18, and it may be decreased with inadequate protein intake. Ketones is measured in the urine or the blood. Its presence can indicate anaerobic metabolism and breakdown of muscle proteins. People find ketones in their bloodstream or their urine in low-carb diets, and diabetics that have a deficiency of insulin. Ketogenesis in people without diabetes could be effective for weight loss and is shown to treat epilepsy and other neurological conditions. The brain uses an alternative energy other than glucose. Ketones for diabetics are dangerous, however. The liver keeps releasing ketones when there is not enough insulin produced by the pancreas. This can cause a spike in blood glucose levels that become very unsafe, such as in the 400 to 600 range. When doing nutritional assessments, it's important to consider that drug and nutrition can interact. Patients at risk are ones that have polypharmacy, taking multiple medications at one time, poor nutrition, chronic drug use, alcohol use, using high-potency vitamin mineral supplements that may or may not be well regulated, and the elderly. The Joint Commission on Accreditation, or JCO, requires that patients receive information on medications that have nutrition interactions and that a nutritional screen is performed. Medication used for long periods of time can deplete the body of nutrients. For example, overuse of antacids can deplete bones of calcium. Also, lots of caution should be used with herbal supplements that may or may not be well regulated, as I mentioned. This is a helpful chart that shows the symptoms and then the medications that cause these drug and nutritional interactions. Decreased appetite may be caused by decongestants, stimulants, antihistamines, anti-neoplastics or anti-cancer drugs, and bulk-forming laxatives. Also, medications can increase appetite, like corticosteroids, antidepressants, and Megace, which is an appetite stimulant. Medications cause smell and taste changes, such as lithium, ACE inhibitors, and many antibiotics. It's important to monitor gastric irritation, such as NSAIDs, aspirins, iron, antibiotics, and watch for signs of GI bleeding. There are luminal changes within the ileum and small intestine, large intestine caused by laxatives, as well as changes in the gastric pH of the intestines. And then there are certain agents, such as lipid-lowering agents and mineral oil, that can cause complex luminal changes. Thinking about damaged mucosa within the oral and the nasal pharynx area, things such as anti-gout, anti-neoplastic, methotrexate, alcohol, a lot of your cancer treatment drugs, things just don't taste the same. The oral mucosa has been damaged, and it makes it difficult for patients to eat. Corticosteroids alter metabolism. Warfarin or Coumadin in antibiotics can interfere with vitamin metabolism. You have to be careful because warfarin thins the blood, so patients that eat a lot of green leafy vegetables or things with vitamin K need to kind of limit not overdoing that because they're taking two things that then thin the blood. Opioids and antipsychotics and decrease peristalsis and increase cholesterol absorption. And then your steroids and contraceptives deplete absorbic acid. Patients in a hospital setting or rehab setting or skilled nursing facility may have several types of diet modifications. NPO means nothing by mouth, and you need to look for the MD order because it might say NPO after midnight, so they can have a procedure done the next day. They may say the order NPO, except the patient may take medications with small sips of water. The patient might be NPO with ice chips are okay. A clear liquid diet, your clear liquids include things like apple juice, coffee, water. No juices with pulp or that are thick are considered clear liquids. Full liquids are more of your soups, the juices that do have pulp in them. There's pureed, which think about the consistency of a baby food. Mechanical soft is a little more like regular food, just softened for someone that might have dental issues, other issues with chewing, dentures, ability to swallow. It just makes it easier for them. Then, of course, there's your regular diet, and then looking for a regular diet but that has disease-specific modifications like cardiac, renal, or a diabetic diet. Continuing on with diet modifications, there are people that need to be lactose-free because their body cannot digest the enzyme lactose. They're vegetarian, vegan, and pescatarian. It's important to understand what your patient can and cannot eat based on their type of vegetarian diet. Cancer diets, high fiber diets, people that need to be gluten-free or gluten sensitive. Renal diets help monitor protein intake and are really important for patients with end-stage renal disease because the kidneys cannot process protein. Also things like renal calculi, where patients have kidney stones, need to cut back in protein for those patients. Then there's high protein diets where we do want more protein, so wounds can heal, trauma, patients can recover faster. Low sodium, low cholesterol, these are all important for heart health. Peptic ulcer, for someone that maybe has an ulcer, we need to cut back on acidic foods that will further irritate the ulcer. Low residue diets are important for patients that have IBS or irritable bowel syndrome or diverticulitis, where little ducts, little polyps develop inside the intestines that can trap things like seeds. So seeds and nuts are not good for these type patients. The consistent carbohydrate diet, or the American ADA, American Diabetic Association diet. This is what you call a patient who has diabetes, their diet in a hospital should be called consistent carbohydrate. Nutrition plays such an important role in disease prevention, particularly in cardiovascular disease, or CAD. It's important to look at weight control, increasing the amount of lean body mass. This means we need to exercise. Omega-3 fatty acids such as salmon, flaxseed, walnuts, almonds, and soy are good heart-healthy forms of fat. Vitamin Z and C and lipoic acid help support heart function. I want to look at reducing saturated fats, going to non-fat dairy, avoiding fried fast food, high-fat packaged food, and solid fats, your hydrogenated fats. Monounsaturated fats like olive oil and canola oil are the best used for cooking. 4 to 8 ounces of red grape juice or wine daily. There are numerous evidence-based studies that this has been beneficial to people with heart disease. Increasing fiber in the form of legumes, oats, barley, apples, broccoli are just some examples. Wanting to use those complex carbohydrates, looking at packaging so that first ingredient says whole grains. You don't want anything to be stripped of its nutrients. And then dark chocolate, that's the best prescription ever. At least 70% cacao to make up dark chocolate so you don't have the added sugar and fats that lesser chocolates might have and more milk chocolates or white chocolate. The DASH diet is a dietary approach to stop hypertension. This is a food pyramid that highlights the components of a DASH diet, where we want the focus to really be on the vegetables and the fruits and the grains, switching to the low-fat dairy, using healthy oils, such as your olive oils, and then limiting kind of the sweets and the processed food. This is healthy for everyone, but really important for someone that's trending towards hypertension and coronary artery disease. The Mediterranean diet pyramid is really a contemporary approach to delicious, healthy eating. It just says, you can have a variety of foods, really focusing on fruits and grains and vegetables as the basis for your diet. Lots of fish and seafood, drinking water, and drinking wine or grape juice to help with heart disease. Looking at poultry, eggs, and cheese. These are okay, just limiting them. And then meats and sweets. So, not saying that you can't have the steak if you want the steak or the chocolate cake if you want the chocolate cake. We just have these in smaller portions and eat them less often. Respiratory disease and nutrition also go hand in hand. If somebody has respiratory disease, they're at a decreased nutritional intake related to fatigue, having a poor appetite, and just discomfort. They have shortness of breath and may be brought on by smoking. Smoking changes taste buds, and altered sensory of food does not taste the same. A person with respiratory disease requires increased calories due to the increased workload of breathing. They are often in a catabolic state, which means they're burning off fat and muscle or protein stores. There can be GI distress. They show signs of malnutrition, decreased GI muscle mass, decreased GI structure, and decrease in peristalsis. Normal, we need 36 to 72 kilocalories to breathe. In a late-stage COPD patient, they may need up to 430 to 720 additional calories because of their disease process. Respiratory patients retain their CO2. So the goal is to reduce CO2. Fat calories produce less CO2 than carbohydrates, so a higher fat diet is recommended in these patients. Just think about it. Smoking is not a good idea for weight loss. Healthy diet is also a big component of cancer prevention. Healthy diet, weight management, exercise, all these three things help in aiding cancer prevention. Looking at the risk, consuming fats, lots of alcohol, pickled and smoked foods, or cooking meats at high temperature can increase the risk for cancer. Chemical exposure from cooking in plastic containers, plastic wrap, styrofoam, and BPA-containing products. BPA is a form of processed synthetic plastics, so careful to look out for BPA-free water bottles and containers. Industry has done a big push to make most things BPA-free now. Just always double check that what you're using and cooking with is BPA-free. Pesticides and toxins. It's always important to wash your fruits and vegetables, whether you get them from a farmer's market or the grocery store. Considering that fish contain mercury, and mercury levels and toxins are found in all forms of seafood, and some types of fish have more toxins than others. There is safecatch.com. This tells the best fish to eat. It looks at mercury levels in all fish and also looks at things like where fish have been overpopulated, overfished, farm raised versus fresh caught, fish line caught. So some important considerations if you are eating a lot of fish in your diet. There are certain things that we can do with our diet to be protective against cancer. Eating things with vitamin A, C, E, and carotene. You want a colorful assortment of fruits and vegetables. Eat the rainbow. These fruits and vegetables contain antioxidants to defend against free radicals that may alter cells and cause cancer. Organic is great, but some fruits and vegetables are not worth the extra cost. Look at the Dirty Dozen list to see which are best to buy organic. When all possible, go to a farmer's market. Fresh is less expensive and is also local, so less pesticides are used because it doesn't have to travel as many miles. Soy, lycopene, and green tea have also been shown to have chemical properties to help protect against cancer. Diet helps with immune function and infection. Your B6, B12, folic acid, niacin, vitamin E, C, iron, and zinc are all important nutrients to get to help your immune function. Making sure you have adequate protein. Keep cold foods cold and hot foods hot to their appropriate temperature. It doesn't take long for bacteria to grow. Thinking about summertime barbecues, things that are left sitting out for really more than an hour, especially if they're mayonnaise based. You need to be really careful. using food-safe measures to prevent this bacterial contamination and foodborne illness. Insulin resistance. Insulin resistance is both blood glucose and insulin levels increase within the body. The insulin puts glucose into the cells, and the cells become resistant to this insulin due to the lack of receptors or faulty sites. As people begin to gain that belly fat, coming to that apple body shape or weight above the waist, they are at a higher risk for insulin resistance. This is caused by inactivity and obesity, and it's a risk factor for all cancers, type 2 diabetes, and coronary artery disease. So for prevention for this, you need to avoid large amounts of processed sugar and food products, eat those complex carbs. It's helpful to avoid large meals where you may overeat and instead transition to 5 to 6 smaller, healthier meals or snacks a day. Strategic snacking helps avoid low and high blood sugar spikes, and never skip meals. A normal BMI, and then exercise. Exercise is key for everyone. For individuals that may not be getting adequate nutrition, there are certain nutritional supplements. You'll see these used both inside and outside patient care settings. Orally, there's Ensure shakes, there's Nephro shakes for patients that may have renal issues, Boost. Glucerna is a diabetic form of like an Ensure or Boost shake that really monitors sugar, their decrease in sugar. Magic Cup is a great form of this high protein ice cream that especially patients that don't have much of an appetite, it's something you can really get them to eat that they will enjoy and have good protein and fat in it. If patients have to be switched over to enteral feedings, this is whether it's for a JAG tube, PEG tube, or your small bore DIPOF feeding tubes, they'll have different formulas of tube feeds such as Jevity, Osmolite, and Nutrin are a couple of the name brands that you may see. Then there's parenteral nutrition, or PPN or TPN. This is the form of nutrition that goes through an IV. It's a special blend of amino acids, proteins, and fats, and it's prepared in the pharmacy. Some things to keep in mind that TPN and PPN are appropriate for a patient that's had loss of their GI function. So we can't really give anything down the GI tract, therefore it goes in the IV. Tube feedings can cause diarrhea. You may need to add bulk-forming fiber supplements. Think about it. If your patient is only receiving a liquid diet, the consistency of their stool, well, it's going to be liquid. And then patients can have a PEG tube and take NPO as well. Maybe they got the PEG tube after severe trauma or a stroke where they weren't able to swallow for a small period of time. Then now they've gone through speech therapy and they're swallowing better so they can take things orally. But we've maintained the PEG tube because even though this patient may eat orally, they're not taking in enough calories. So they'll do supplementation through the PEG tube. Maybe they'll do that tube feedings at night or before bed. So in looking at nursing diagnoses regarding nutrition, altered nutrition are less than body requirements. So who is at risk? The elderly. They cannot prepare and shop for food. Sometimes they forget to eat as cognition and dementia issues arise, and also economics. Many elderly patients are on a fixed income, having to decide between getting their medications or getting food. As we age, there's a decreased sense of taste, and metabolism slows down as well. Men and women, there's social pressures from media, so eating disorders. This Thin is a good documentary to watch on eating disorders that took place in a specialized center down in Florida and kind of reviews some of the psychosocial issues that these patients went through. And then these bottom pictures are of drug abusers and alcoholics. Things like meth and heroin. Patients, these individuals become so transfixed on getting that drug fix that nutrition is not important. So you'll see them get these tight, gaunt, frail faces, and a big indicator is the teeth, or loss of the teeth, of the gums. They just don't have adequate nutrition. Then there's the other end of the spectrum, alter nutrition more than body requirements. So some risk factors for this are, of course, lifestyle, not staying active, eating the wrong types of food, eating too much foods, and 35% of the U.S. adults are obese. Obese, not just a little overweight, but obese. 34% are overweight. And unfortunately, this is being passed down to children. 17% of children and adolescents are obese, and 32% are overweight. They are 3 times more prevalent to be overweight than one generation ago. And this is pretty sad. I don't know if some of you recognize the movie down at the bottom. This is a Disney movie, WALL-E, and it shows what happened if a society, didn't get up and move around. They're riding along on these movable chairs. They're not walking or exercising, and of course they're sitting there drinking a big gulp. So kind of some staggering statistics about the state of our society. You can find more information about this from cdc.gov. Then some other nursing diagnoses. The patient might not show signs of obesity or undernutrition, but they could be at a big risk for it. Impaired swallowing, after traumas, after a stroke, this puts them at risk for aspiration. They can't swallow adequately, it's going into the lungs, so now we need to make the patient NPO. So they're going to have to be on an alternate form of nutrition. Altered health maintenance, and then knowledge deficit. There's so much information out there about nutrition and different diets and fad diets that people can find themselves with inadequate knowledge of correct nutritional resources for them. So there are lots of good references for nutrition. These are just some of them that I used, and I encourage you, to reach out as a nursing student, as a nurse. You're going to have friends, you're going to have family, they're going to ask you all types of questions about nutrition. Be sure to point them into the right direction. I feel like healthcare providers, we need to be the good example for ourselves, for our families, for our community, for our patients. Really practice what we preach. So any questions, please feel free to reach out to me or Dr. Patterson. This has been your nutritional lecture, and I hope you take this information and carry it with you, not just in Nursing 120, but throughout your personal life and in the care of your patients.